Word on Health, the report with its finger on the pulse of popular medicine, with Paul Pennington. Word on Health, for your very best of health.
Hello and thank you for listening. Coming up, I'll be talking to Helen Strongman from Narcolepsy UK. Vascular surgeon and chair of the Circulation Foundation, Rachael Forsythe, joins me to discuss PAD. And I'll be looking at calls from the charity Harry's Hat for increased routine head size monitoring of infants. But first, despite the government repeatedly stating that early diagnosis of dementia is a priority, the Alzheimer Society's new Unlocking the Door report, released to coincide with Dementia Action Week, highlights we're some way off achieving that goal. Michelle Dyson is CEO of the Alzheimer Society.
Dementia is the UK's biggest killer. It used to be heart disease, now it's dementia. And yet people are waiting 3.5 years to get a diagnosis. The key thing is what you could be doing in that time to help alleviate the symptoms. Look, there's no cure for dementia, but there are drugs that can help with the symptoms that you ought to be getting. But obviously, if you've had no diagnosis, that you're not going to be able to access those drugs. You can also get access to cognitive stimulation therapy. So that's a non-drug intervention, which is proven to help. And people just fundamentally find it helpful to understand why they're experiencing what they're experiencing. 90% of people who get a diagnosis say that they find it helpful. And now we have a huge number of trials going on, particularly for Alzheimer's disease. There are 130 drugs in trial for Alzheimer's disease. If you've got a diagnosis, you can be on one of those trials that might help you personally, but you'll certainly be helping people in the future. And people with dementia like the fact that they can help defeat this dreadful disease for those who come after them.
Where do the problems lie?
Partly, I think people are still scared of getting a diagnosis and they have a sense that there is no cure. So what's the point? But also, there's a real problem with the system. And that's why we're calling on government to have a national structured clinical pathway so that when people come to you to say, I'm worried about my memory, it's really clear what the expectations are on the system. None of that exists at the moment.
It has to be said there have been commitments to improve resources available, but with an ever-growing number of dementia cases, is there also a capacity issue with regards to getting access to the likes of memory clinics?
Yes, there is. And there's a capacity issue with the scanning systems that you need in order to do brain scans. Dementia is an umbrella term underneath which there's a number of specific diseases. So Alzheimer's disease being the most common, but there's also vascular dementia, various types of different diseases that sit underneath that umbrella term. And you can tell what disease someone has when you scan their brain. And it really does matter to have that accurate diagnosis. And that's one of the things that we, Alzheimer's Society, are calling for, not just an early diagnosis, but an accurate diagnosis. And then depending on the type of dementia that you have, we absolutely need to see those clear pathways, what's meant to happen to you next. And that would obviously help GPs, it would help everyone in the system. And fundamentally, it would help patients to know what they can expect and what they should have to cope with what is a very urgent and growing problem.
Alongside getting an early and accurate diagnosis, one of the most striking lines I read in your report is that some families felt that they were released into the wild after being diagnosed, and people shouldn't be left without support when they need it most. I understand that there is activity at a government level which could be an opportunity to address the issues.
The government has committed to what they call a modern service framework for frailty and dementias, and they say they're going to publish a draft in September and then the final version in December. And we need to see in that plan the clinical structured pathway with all the different stages in it. So it's absolutely clear what people can expect, what the system must deliver. And we need to have clear standards for every stage of that journey. And then you need to have data to hold everyone to account. And we don't have any of that at the moment. So our ambition is to see all of that set out in that framework when it's published. We have an open letter. People can find it on our website. We would love as many people to sign it as possible because this is a great opportunity to get that ambition in dementia that we've seen in so many other diseases. We need to now see it in dementia, and this is our time.
My grateful thanks to Michelle Dyson. To reach the Alzheimer Society, visit our links page at wordonhealth.com. That's wordonhealth.com.
Word on Health, for your very best of health.
Studies show that 1 in 5 of us don't get enough sleep, but for the 14,000 who've been diagnosed with narcolepsy, they can't get enough of it. Helen Strongman is a director of the charity Narcolepsy UK and who also lives with the condition.
So narcolepsy, it's a neurological condition and it really affects the regulation of the sleep-wake cycle. So it's commonly caricatured as causing people to fall asleep in comical situations, but it's much more complicated than that. It's got multiple symptoms and it affects people both during the day and during the night. There's type 1 and type 2 narcolepsy. And the most well-known symptom is this irresistible need for brief naps during the day. And that might be really sudden, but often people have some warning that it might happen. People also struggle to sleep throughout the night, and they might have sleep-related hallucinations, really scary dreams, and sleep paralysis. People with type 1 narcolepsy also have cataplexy, and this is a sudden loss of muscle tone that can range from just a kind of facial drooping around the cheeks, say, or it could be falling to the ground. And the emotions that cause that vary between people, but it's often laughter, humour, maybe anger. Type 2 has all of the other symptoms except cataplexy.
Helen, do we know what causes narcolepsy?
Type 1 narcolepsy happens when the brain stops making orexin, which is a molecule that helps to regulate the sleep-wake cycle. And it's likely to be because of an autoimmune reaction to the neurons that produce orexin. And that reaction is associated with an immune system gene variant. So there's a gene variant that nearly everyone with type 1 narcolepsy has, but so does a lot of the rest of the population. So that's a beginning, and then narcolepsy might be triggered by specific bacterial or viral infections.
People with a family history of narcolepsy are at higher risk. However, most people with narcolepsy don't have a close relative with it. It can occur at any age, but commonly begins in adolescents, teenagers and young adults up to the age of 30. How long does it take on average to be diagnosed?
In kind of recent years, it's taken 4 or 5 years between first symptoms and diagnosis. I think it's all sorts of reasons. So there's this societal attitude towards sleep where we don't really take sleepy people seriously or we judge them. I think it's difficult for people to recognise that there's something wrong, and for the people around them, such as their teachers or family or colleagues, to do the same. We've done some research with GPs and they have a low awareness of narcolepsy as a relatively rare condition. They don't really know where to refer people to. And then it gets to the specialist care, and sleep as a specialism isn't very well recognised. It kind of falls between different specialties, and there isn't much capacity for that.
And the availability of specialists, I understand, does depend on where you live. Are there a range of medications that can help once you've been diagnosed?
There's lots of drugs, old and new. The effectiveness and side effects really vary between people. So it can take a lot of time for people to get to the right treatment for them. And then that effectiveness might change over time. And so they might have to switch drugs. But really excitingly, there are new drugs under development. And these drugs directly act on the orexin pathway that causes type 1 narcolepsy. From what I've seen, they're likely to be twice as effective at managing daytime sleepiness in people with type 1 narcolepsy and to treat other symptoms as well.
And what adaptations have you found that has assisted you live well and work full-time with narcolepsy?
Try to be aware of how narcolepsy is affecting you, and then to be kind to yourself and to adapt your life around it. So scheduled naps can really help, but they can also be logistically complex. You need to be able to persuade people to provide you somewhere that you can sleep safely. I've also found it really helpful to identify as being disabled, and that has given me confidence to ask for reasonable adjustments at work and to understand the societal barriers that impact my well-being.
My grateful thanks to Helen Strongman. To reach Narcolepsy UK, visit our links page at wordonhealth.com. That's wordonhealth.com.
Word on Health, for your very best of health.
Around 1 in every 770 babies are born with hydrocephalus, which makes it uncommon but not rare. It's one of the more frequent neurological conditions requiring surgery in children. Awareness is considered to be insufficient, early recognition can be missed, and families report delayed diagnosis due to lack of knowledge. Victoria Glover is from Harry's Hydrocephalus Awareness Trust, otherwise known as Harry's Hat.
Hydrocephalus is a condition which is characterised by an abnormal build-up of of fluid on the brain. When that fluid builds up inside the skull, that can cause pressure, and pressure on the brain for a prolonged period of time can cause brain damage and ultimately lifelong disability, unfortunately.
Do we know what causes it?
Hydrocephalus can be caused by so many different things. I think in the NHS, they have maybe over a dozen ways of coding hydrocephalus based on the cause. For example, a bleed on the brain can cause hydrocephalus, a brain tumour. In my son's case, he has an arachnoid cyst in his brain, which caused a blockage and caused hydrocephalus. You can even get hydrocephalus if you've had a really bad head impact, in a car accident or something like that. So there are so many different ways that you can get it. So it's not necessarily as straightforward as a standalone condition. I suppose you could class it as something that is caused by something else.
For those mums-to-be who are following all the health advice they're given during pregnancy, is there anything additionally they can do to prevent their newborn developing hydrocephalus?
You can't blame yourself if your child gets a diagnosis of hydrocephalus at all. It's one of those things, unfortunately. There are babies that are more likely to get it. For example, preterm babies, because they are more vulnerable to having bleeds on the brain. But no, there's no way that you can cause it as such, no.
Talk to me about the impact that hydrocephalus can have on the baby's development.
If you catch it early, then the child won't have any learning difficulties, hopefully. But if it isn't caught early, the more pressure, the more damage on the brain. Unfortunately, we tend to see the more impact it has on a child's development, issues with mobility and learning difficulty and various other comorbidities that exist alongside that. But then we also have children that we support within the charity who, for all intents and purposes, you might look at them and you might not know that they've had multiple brain surgeries throughout their life. So it really is a spectrum.
How do we catch it early?
One of the things that we're really passionate about is routine infant head measurements. If we routinely monitor head circumference in those babies in the community that don't have any risk factors that we know of to start with, if there is a sudden jump, that's a sign that maybe something needs looking at and for some further monitoring or referral to a specialist service. If your child's head is quite nicely following the chart as it should do, you've got no need to worry, and the majority of people listening to this will never have any need to worry. But it's just that sudden jump, and that's why head measurement over time is important, because one measurement on its own doesn't really tell you anything at all.
And we should stress that these are routine, non-invasive head measurements that should be made by health professionals. I know from talking to you off microphone, you've taken this campaign all the way up to the UK government's health minister, who has been receptive. The mean average onset of hydrocephalus is at 4 months. How does the UK compare in terms of routinely measuring babies' heads with other countries?
Routinely, a child should get 2 measurements. One around the time of birth before they leave hospital, and that should be charted in your red book that you're given when your baby's born. And then again at around the 6 to 8 week check when you go to the GP, they should also measure the head with a paper tape measure, and again jot that down in your red book so that you've got a comparison between 2 numbers. That is it. Finland and Norway do 10 and 11 measurements respectively. America takes 8 measurements. France, I think, takes around 11. Germany takes 8. I mean, even the Republic of Ireland do 3, so that's 50% more than we're doing. We feel that if we were to have a measurement around 4 months, which is actually around the age that you would end up having your vaccinations, that hopefully we would catch the majority of them, we think. But it varies from baby to different baby, depending on their circumstances. And obviously those babies that are already identified as having risk factors would be monitored in a different way. But we're talking about those babies in the community that a mum or a dad has taken them home. They've got no idea that anything may be wrong. Those are the babies that we're sort of trying to target with this campaign.
My grateful thanks to Victoria Glover. To reach Harry's Hat, visit our links page at wordonhealth.com. That's wordonhealth.com.
Word on Health, for your very best of health.
Peripheral artery disease, or PAD as it's otherwise known, is a common and under-recognised problem affecting 1 in 5 people over the age of 60, but increasingly affects younger people, especially in those of us with high blood pressure and or diabetes. Sadly, the most severe cases of PAD are associated with a prognosis worse than most common cancers. Data suggests publicly that around 70% of us have never even heard of it, a situation the Circulation Foundation is trying to change. Their chair is Rachael Forsythe, a consultant vascular surgeon in Edinburgh.
Peripheral artery disease is disease of the arteries outside of the heart, so in the peripheries of the body. We most typically talk about peripheral artery disease relating to the legs. They're the most common place that we vascular surgeons deal with. Artery disease is a narrowing or hardening of the arteries that occurs usually over time And that's as a result of often smoking, diabetes, high blood pressure. What happens is the body builds up some calcified hardening of the arteries. And as time goes by, that can narrow down, and sometimes the artery can block off altogether. We should really think of it as analogous or as a similar kind of problem to coronary or heart artery disease, because it can, in some situations, in its worst form, lead to amputation of the leg. And unfortunately, it's actually a marker of artery disease elsewhere. So it's not just about the legs here. A large population of people who have peripheral artery disease also have the same process occurring in their heart arteries or their arteries leading to the brain. And therefore, these people are at risk of subsequent heart attacks and strokes, even if they don't have any symptoms of heart problems like angina. So it's important to recognize the bundle and the sort of severity of the situation when someone's diagnosed with peripheral artery disease.
How might peripheral artery disease manifest itself?
In the mild form of peripheral artery disease, usually the most common early symptom is called intermittent claudication. Intermittent being it doesn't happen all the time. Claudication essentially tells us that the muscle in either the calf or the thigh, depending where the artery problem is, becomes crampy essentially. And that normally happens at a reproducible distance, so the same distance of walking every time. Maybe someone can walk 100 yards, then they have the calf pain. It's really sore. They might walk a few more yards and they have to stop. When they stop walking, the pain settles down. That's the typical classical kind of presentation of intermittent claudication. It's usually worse up hills as well. And I kind of describe it to patients as angina of the leg. The arteries in the leg are struggling to get the blood to the muscles as quickly as they need to get the blood when someone is walking, because clearly when you exercise and when you walk up a hill, your muscles are going to need more oxygen, nutrients, and blood. And if it's the blood is traveling through narrowed or blocked channels or traveling round blocked channels, then the blood won't get there quick enough, and the muscles will be telling you that by becoming sore. So that's the classical symptom associated with the milder form of peripheral artery disease. When we say mild, claudication can still have a massive impact in people's lives. Looking at maybe a younger population who's still working, we get plenty of joiners, plumbers, tradespeople, or people who need to walk around for the job that aren't able to continue their job because they need to stop every 50 yards, and that's not compatible with a busy, active job. As the disease gets more severe, going on to the severe end of the spectrum, the symptoms do become more serious, and oftentimes people are a bit more aware that there might be something nasty go on. Because at the severe end of the spectrum, we have a sort of syndrome called chronic limb-threatening ischemia. And those are the patients who have really poor outcomes, unfortunately. Chronic being something that happens over time, so it has not just come out of the blue. Typically, that means going from this claudication, pain on walking, to the pain that coming on earlier. The distance that you can walk becomes shorter and shorter, and then maybe you feel a bit of pain in your foot when you're doing nothing. And then typically patients with chronic limb-threatening ischemia might have pain in their foot at night, because of course at night, when your leg's elevated in the bed, you don't have the use of gravity to help the blood get down to your foot. And the classic thing that our patients say is that I have pain in my foot that wakes me up from sleep, and I have to hang my leg over the side of the bed. That's to use gravity. That's the patient's natural response. Hang the leg over the side of the bed so a little bit of gravity can help the blood get down. And then, unfortunately, some people progress to developing wounds on their toes, particularly, or on their foot that don't heal up because, again, there's just not enough blood supply to get those wounds healed. That may be trauma that someone's not recognized. Stubbing a toe is the classic. Or sometimes wounds can just start to develop themselves because the skin gets thin and brittle and starts to crack. The heels start to crack, and you don't have enough blood supply to heal that. And those patients are in a limb-threatening situation. And those are the patients that when they present to their GP, often it's quite clear there's something pretty bad going on. If someone's toe's gone black, I think the patient's probably fairly worried about that, as will the GP. Or if they're having this classic hang the leg over the side of the bed at night symptoms. The other thing about peripheral artery disease is it can be in the background without patients having any symptoms at all, because this hardening can happen so slowly over time that the body can try to compensate for it. but you still have that cardiovascular risk. Once you have narrowing of the arteries in the legs, you still have the risk elsewhere. And the other side of things is that sometimes it doesn't present in that fashion with pain that's reproducible at the same distance every time. Of course, not everyone follows the textbook with their symptoms.
If caught in those early stages, PAD can often be successfully managed or treated. So if what we're discussing here strikes a chord with you, please talk to your GP. And outside of those going through the mild stages, there's diet, exercise and lifestyle measures we can take to reduce the likelihood of the hardening of the arteries. Whilst I know we have seen advances in surgical procedures to help those with severe PAD, the outcomes are not what you and the vascular health community would want for these patients. As a charity, you've been lobbying policymakers to bring about change. What's been your focus?
The Circulation Foundation has been working with a growing coalition of stakeholders, along with MPs across all parties, working with the Royal College of Podiatry on bringing momentum to this awareness campaign. There was a white paper released making some suggestions for commissioning documents for national pathways, and that's to improve access to care for people with peripheral artery disease. We need to get people through the diagnostic pathway quicker, but we're also working on some public awareness campaigns. 70% of the general population will be in the dark about this. And so we're kind of working in those sorts of strategies as well.
My grateful thanks to Rachael Forsythe. To reach the Circulation Foundation, visit our links page at wordonhealth.com. That's wordonhealth.com.
Word on Health. On air and online 52 weeks of the year with Paul Pennington. Word on Health. Your personal prescription for your very best of health.